Good morning, colleagues and students. Thank you very much for the opportunity to talk once again about this novel technique. Uh, we have no financial disclosure to be made, and the study was approved by the Institutional Review Board at Mahatma Eye Hospital, Nagpur. It was part of the thesis program of one of our ophthalmology residents. All of us are acutely aware of presbyopic difficulties, and we are used to prescribing bifocals or progressive addition lenses in this adult group of patients. However, it's to be noticed that 80% children having Down syndrome suffer from presbyopia from childhood. 50% children with cerebral visual impairment also have presbyopia. 30% children with foveal hypoplasia associated with albinism or PARC6 gene mutation or aniridia also suffer from accommodative abnormalities. A large number of children with ectopia lentis or amblyopia, strabismus, asthenopia, as well as children on low dose atropine also have dysfunction of their accommodation. So we need to recognize these abnormalities so that appropriate management, which is usually a bifocal prescription, can be given to these children. So methods available for assessment of accommodation have been dynamic aberrometry, autorefractometry, and dynamic retinoscopy, of which dynamic retinoscopy is the only clinical method. Dynamic aberrometry and autorefractometry are not popular because of significant underestimation that it has with assessment of accommodation. Dynamic retinoscopy in India has not become very popular because of little difficulty in terms of scissoring of reflex in presence of astigmatism, as well as inability to perform the test rapid enough and bilaterally simultaneously. In our survey of group of pediatric eye surgeons of Mumbai, we realized out of 22 members having an average experience of 5.8 years in practice, only one pediatric eye surgeon was confident enough with the estimation of accommodation using MEM method of dynamic retinoscopy. So here, which is relatively simple, can be done on both eyes simultaneously and significantly faster and works better in patients having large astigmatisms. You just need to look at the patient's red reflex while patient is being asked to look at a distance wearing an optical correction. It could be a dark room or it could be a reduced illuminated room. When the child looks at a distance, you can notice a superior crescent, and as the child starts accommodating, the crescent of the red reflex starts moving, reducing in the upper segment and starts appearing a new crescent inferiorly that tends to keep becoming bigger in size. So more the accommodation, bigger is the crescent inferiorly. This is a video recording through a direct ophthalmoscope. When the child is looking at distance, there was a superior crescent, as you see over here. And as soon as the child will start looking at an accommodative target at near, an inferior crescent, and as the course increasing, how quickly it happens, how well it happens, whether it is equal in both eyes or no, and whether it is sustained or no. These four parameters can tell us about the quality of accommodation using this test. One more testing that can be added to this is measurement of the magnitude of accommodation. So this test can be converted into a quantitative test by interjecting a neutralizing lens in front of accommodating eye. As you see over here in this 40 centimeter accommodation, it's neutralized at minus 0.5 diopter, and in a 25 centimeter, it's being neutralized with minus 3.5 diopter. The aim of my study was to validate the reliability of this particular test using several methods. We first compared both the methods qualitatively in normal subjects. Then we applied it in 1,000 consecutive patients in pediatric ophthalmology clinic where comorbidities were also detected, followed by its comparison in estimation manner. That means we were measuring the magnitude of loss of accommodation using the two techniques in normal subjects. We also had our fellows using the test so that we can check the inter-observer validity. And of course, finally, we validated the scale among pediatric ophthalmology consultants of Mumbai. In the first part of the study, we compared dynamic distance ophthalmoscopy with dynamic retinoscopy. We had to have 32 eyes in an observational, comparative, and masked manner. 2 observers performed DDDO and DR in a separate manner on children who were 5 to 16 years of age visiting a pediatric eye clinic who were perfectly otherwise normal. So condition. What we found was the sensitivity, specificity, as well as the predictive values were in excess of 90%, 96, 95% was an average, and a very high kappa coefficient between the inter-observers. Followed by this, we applied this technique to qualitatively measure the accommodation and its dysfunction in pediatric ophthalmology clinic. 1,000 children were evaluated in the masked manner, and we found the sensitivity and specificity were very impressive. This was followed by evaluation of magnitude of accommodation using interjection method or with the MEM method of dynamic retinoscopy, in which we had to have 60 patients included. Again, it was an observational comparative. However, it was a non-mass study. The same observer in sequence performed EDDDO first, followed by EDR in the same similar group of children. However, the comparison of response accommodation was done at 40 centimeters, 25 centimeters, 10 centimeters, as well as 8 centimeters. So 60 multiplied by 8 readings were acquired. When compared, we found at 40 centimeter response accommodation using EDDDO as well as EDR was around 3 diopter. At 25 centimeter, it was 5 diopter. At 10 centimeter, the child could exert 9.8, 9.5 diopters. And at 8 centimeter, around 11 or 11.3 diopter. So there was a very minimal overestimation using EDDDO. However, the Pearson correlation was in excess of 0.9. Then we compared the EDDDO with EDR under partial cycloplasia and mydriasis to evaluate the onset of accommodation, the cycloplasia using cycloplegic agent in 12 eyes, 6 children, where again at 4 different distances, the measurements were required, making to around 48 measurements. And we had a mean response accommodation in this particular set of patients, 6.62 and 6.3, again giving 0.3 diopter of extra accommodation with EDDDO. Inter-observer variation between the two techniques was compared in 10 eyes of 10 children. 40 measurements each were obtained by observer 1, masked from observer 2. These were pediatric ophthalmology fellows, and there was a very high correlation coefficient between the two observers. Kappa value was high. Eventually, the test was subjected to survey with the pediatric ophthalmologists, who were provided with this standard photograph, as you see over here. From left panel in the upper part to the lower right panel, there is an increasing amount of accommodation, which was appropriately utilized by the faculty of GPOS. These are 18 pediatric eye surgeons who use this standard photograph to detect abnormal accommodation in children between having an experience of 6 months to 19 years of experience among pediatric eye surgeons. And 16 ophthalmologists could correctly identify accommodative abnormalities using this particular test and the standard photographs. The limitation of either of these two methods, EDDDO or EDR, is interjection of the lens, which itself can induce accommodation and produce falsely higher accommodative values of response accommodation in children. And hence, it is necessary that we do a quick interjection and removal of the lens while we apply this test. In future, studies can be performed using a non-interjection method, using an mobile app such as a GCK app, which is more like a photo screener method of performing the same test. In conclusion, I feel DDDO as well as its modification EDDDO are easy, rapid, objective, having a very good qualitative as well as quantitative assessment of accommodation, and they have very good correlation, inter-observer variation, and they are valid tests to be utilized is routine in pediatric ophthalmology clinic to assess abnormal accommodation in children, and it offers a unique advantage of being able to assess accommodation from both eyes simultaneously, and hence it becomes the only clinical available test to detect anisotropic accommodation in children. Thank you.
Thank you, Mihir. That was wonderful. I think a very easy and a way of finding out accommodation, not using anything which is not available in every clinic. Every clinic has a direct ophthalmoscope practically, and I think great job as usual.
Thank you, ma'am.
Yeah. Only thing is you'll have to spend some time on just mastering this. That's all.
On
Just to spend some time on mastering this skill. That's all.
doing this.